So thank you very much for coming to our Talking Public Health seminar today. And we're very lucky today to have Dr. Zachary Butzin-Dozier. He's an epidemiologist at the UC Berkeley Center for Targeted Machine Learning, and he's got his MPH and PhD from Berkeley. So you're a Berkeley guy for sure. So he specializes in applying advanced methods in epidemiostats and causal inference to observational electronic health record data. And primarily, his research focuses on identifying preventive interventions for long COVID using targeted machine learning approaches. He's got a lot of funding, in particular, NIH a K01 award. He placed third in the NIH Long COVID Computational Challenge. That sounds very competitive. And his recent work has been published in BMC Medicine, Epidemiologic Reviews, and other really high-powered journals, has won several awards, and he's also been supported for his work by Gates Foundation. So we're very lucky to have him here, and I don't know that much about targeted machine learning, so this is going to be, yes, I will. So I'm going to turn it over to you.
Okay, thank you so much, Deborah. So thanks so much for joining, everybody. I really appreciate it. This presentation is titled Evaluating Preventive Intervention for Long COVID Through Targeted Machine Learning, and I'm Zach Butzin-Dozier. For an overview, I'm going to start with an introduction to myself and my work. Then I'm going to tell you a little bit about the data source, which is the National Clinical Cohort Collaborative, or N3C for short. Then I'm going to discuss the analysis methods that I really apply across all of my research, which are targeted machine learning, which can also be thought of as applied machine learning for causal inference. I'm going to discuss 3 applied projects. First is a project where we sought to predict long COVID status. So this was a part of the NIH-funded Long COVID Computational Challenge. Next, I'm going to discuss 2 more causal inference-focused analyses. First, where we sought to evaluate the relationship between the use of selective serotonin reuptake inhibitors, or SSRIs, and subsequent risk of long COVID. Finally, I'm going to discuss an analysis evaluating the presence of racial bias in long COVID diagnosis. And I'm going to finish with some summaries around the state of current long COVID research and future directions for my work. So my name is Zach Butzin-Dozier. I'll fly through this because Deborah gave such a great intro, but I'm a postdoc at the Center for Targeted Machine Learning at the UC Berkeley Division of Biostatistics, where my research focus is really focused on applying a causal inference approach to large observational health data. My previous research through grad school, in terms of applied work, I led 2 studies evaluating data from the WashU Benefits Bangladesh trial. And I led a systematic review, I evaluated another study that found determinants of antimicrobial resistance in rural Ecuador. In terms of methodologic work, I led a systematic review of the RING trial design. That's an underutilized trial design that's really effective for settings with high spatiotemporal clustering of disease. I also just recently led a study that really provides an overview of a really cool new algorithm that our groups developed called Highly Adaptive Lasso, which just has really just unparalleled efficiency and flexibility, but has been really underutilized by epidemiologists. For teaching, I teach intervention trial design and epidemiologic methods 1 and 2, and I'm funded by an NIAID K01 award. So first, long COVID, the outcome that we're going to be discussing across all of these applications. We've made a ton of progress in learning how we can prevent, treat, measure acute COVID, but then the long-term effects of this infection remain pretty unclear. Long COVID refers to a really broad range of symptoms across every biologic domain. These symptoms can include things like shortness of breath, cough, fatigue, but that it can also include kind of more rare symptoms like sensory disturbances or issues with blood clotting. So studies that involve active outcome ascertainment, so things like prospective cohort studies or randomized trials, have often found that somewhere between 10 and 30% of acute COVID patients will develop long COVID. But then in observational health data, often something like 1% of the patients will actually be diagnosed with long COVID. So there seems to be a really large gap between the true incidence rate and the observed diagnostic rate. Here I would give a little bit of an overview of the hypothesized biologic pathways of long COVID. I want to include the disclaimer that these are not all-encompassing, and they kind of blend together cause and effect. They blend together symptoms and the underlying biologic mechanism. But this, I just wanted to give you a lay of the land. So first, and I think this hypothesis has really gotten a lot of support in recent months, is persistent SARS-CoV-2. So for patients with long COVID, either the virus or viral particles remain in the body, so folks continue to keep having symptoms. There's also a hypothesis of inflammation. So you may have heard early in COVID about a cytokine storm, where an individual with COVID has a kind of out of control hyperinflammatory response to the infection. Well, this hyperinflammation can then disrupt the inflammation system and have a kind of cascading effect. Similar, the inflammation system is pretty related to autoimmune disorders, which then represent an entire category of then potential long COVID mechanistic biomarkers. And the inflammatory or immune system is also really intertwined with the stress system, where those systems should downregulate or dampen one another. So when there's dysregulation of one system, that also leads to dysregulation of the other. Then finally, or not finally, but we have clotting and platelet dysfunction, where hypercoagulation has been observed in a lot of long COVID patients. And then perhaps the most intuitive is tissue damage. So you can think of somebody has severe COVID and they're on a ventilator. Often that patient then develops lung damage, and that lung damage is going to have long-term symptoms. Next, I want to discuss the data source across these three applications, the National Clinical Cohort Collaborative, or N3C. So N3C was an NIH-funded effort early in the COVID-19 pandemic to say, we need researchers across the country to be able to access national data for COVID research. It's too challenging for folks to have to navigate all of the HIPAA restrictions and the really siloed data sources. So they negotiated between 85 healthcare providing institutions for them to say, okay, share your data with us. We will manage this secure enclave where then we will make sure that the data protect patient privacy and are used appropriately. And it now includes more than 22 million patients. So some strengths and limitations of N3C. And pretty much all of these could be interpreted as both a strength and a limitation, but I kind of tried to group them as well as I could. So first, large sample size, 22 million patients, as I mentioned, which really can leave us well-powered to detect pretty rare outcomes. Then we have complete follow-up, where if a patient is triggered for inclusion, so that's patients at participating healthcare institutions who have COVID-19, and then 2 sociodemographically matched controls for each patient. And so for those patients who are triggered for inclusion, we have all of their data from January 2018 to present. And the data are updated, I believe, like every week or every other week. And there's really high quality data related to medications and prescriptions, comorbidities, and COVID-19. The limitations, for one, there's really heterogeneous monitoring. Unlike a randomized trial or a prospective cohort, where we would say, we want to monitor the person's health status every month. Here, we only have observations when somebody interacts with one of these participating health institutions. So in other words, a lot of missing data. We also have high dimensional data, which means a lot of variables for each person. We have every variable that is in their electronic health record. While you could think of that as a good thing, because you can really adjust for a lot of factors, it can also be a limitation, specifically for model misspecification, which I'll elaborate a little bit on in the next slides. Next, we have lack of biomarker data. So this is routinely collected data. So it's really rare that although we might want something like cytokine levels to determine immune status, it's going to be really rare and heterogeneous who is going to be assessed for these really rare biomarkers. Although they're an interest to us as researchers, it might not be useful or as useful or common in this routine clinical setting. And then finally, generalizability. That's a really big limitation here, where although it is a national sample, it's not a nationally representative sample. So there's oversampling of academic research centers, that the sample is disproportionately for one high healthcare utilizers. That's going to be people who are older and have more comorbidities, but it's also disproportionately white, non-Hispanic, high socioeconomic patients. So next, I'm going to discuss the analysis methods, and specifically their benefits for this data source. So targeted machine learning, as I mentioned, applied machine learning for causal inference, leverages advancements in data science, causal inference, and biostatistics. So this approach really has two main components for the most part. First, we have superlearner. So superlearner is an ensemble machine learning algorithm, which really means that you introduce a library of candidate algorithms that you think might fit the data. So you could include kind of traditional parametric algorithms, something like a generalized linear model, but you could also include things that are more flexible, something like a gradient boosting model or more kind of modern machine learning methods. And then what superlearner does is it develops the best weighted combination of all of these algorithms to best fit your data. The really cool thing here is this flexibility avoids model misspecification. So I mentioned before that a limitation is we have a lot of covariates per person. So in a traditional parametric modeling approach, we have to specify all of those relationships. If we have a lot of relationships to specify, the more variables we have, the higher our chance of getting something wrong. And if we make some assumption about those relationships that isn't true, that's model misspecification. And if that happens, that's going to induce bias. And so here I want to highlight that this is where kind of a lot of traditional machine learning approaches stop. I think there's stereotypes that are totally fair, that machine learning is really good at prediction, but isn't suitable for causal inference, and that it's not very interpretable. And I totally would agree with that if we stopped here with superlearner. But a really cool thing about a targeted learning approach is that we have this second component, which is targeted maximum likelihood estimation. So targeted maximum likelihood estimation is primarily a bias reduction step. That's when we take into account knowledge of what are likely confounders, what are effect modifiers, what are mediators, to really hone in on this exposure outcome relationship. But a really nice thing as well is that this yields a parameter that's interpretable to folks who aren't data science or biostatisticians. You can get a risk ratio, a risk difference. You can even get things that are a bit more bespoke, something like a dose response curve, a conditional average treatment effect. So you can measure something like an optimal individualized treatment regime. And then finally, it's doubly robust, which means that it will consistently estimate as long as you accurately characterize the outcome regression or treatment mechanism. So here I want to expand a little bit on what I mentioned about model misspecification and these concerns, particularly in N3C, where we have a really large sample size, a ton of patients and a ton of data for each patient. So I'm going to have the same scenario, but with 3 different settings where it's going to vary the sample size and our analysis methods. But in all cases, it's the same true relationship. So in this setting, there's a null relationship. There's no relationship between exposure and outcome, and that's a relative risk of 1.0. In all of these settings as well, there's moderate bias. This could be something like model misspecification. You assumed a relationship that wasn't true between factors. You didn't include one interaction term that was actually necessary. So if you have a small sample size and a parametric analysis, you're probably fine. That there might be a little bit of bias induced, but you're going to have little enough precision, a wide enough confidence interval that you're still going to include, your estimate is still going to include that null. So you're still, in your study, you're going to say, we fail to reject the null, and that is the correct response because the null hypothesis is true. But now let's see what happens when we have a large sample size and a parametric analysis. So we're still going to have this little bit of bias that shifts our estimate away from the null, but now because we have such a large sample size, our confidence interval gets super narrow. So in other words, we have really high precision, but low or moderate accuracy. So it's actually the case that if you use traditional parametric analysis methods, as the sample size gets very, very large, you're virtually guaranteed to reject the null hypothesis. And as scientists, that is not what we want. We want to err on the side of failing to reject the null hypothesis. So in other words, there's a really high risk of a type 1 error. But then the really nice thing here with targeted learning methods, with kind of 2 different parts. So first, we have the flexibility of superlearner. So that avoids model misspecification and avoids inducing that bias from making incorrect assumptions about our parameters. But then we also have this bias reduction step with targeted maximum likelihood estimation. This I included here kind of a simplified example, but there's a cool publication that really gives a lot of metrics with really detailed simulations that outlines these properties. So now I want to get into the first of our three examples. So the first was the long COVID computational challenge. So an NIH-funded data science competition where the goal was to predict individual long COVID diagnosis based on the individual history in their electronic health records. This included data from N3C. The sample included around 60,000 patients that were matched at a 1-to-4 ratio of long COVID to not long COVID. And we had data up to 4 weeks after their acute COVID diagnosis date. And that we published this article in JMIR Public Health and Surveillance. And I was really proud that this was selected for the NIH NCATS Spotlight Article of the Month. So for data processing, we extracted 304 features or variables that we hypothesized would be associated with long COVID diagnosis. And then we indexed those variables across 4 time periods. So that was baseline, which is more than 37 days before acute COVID, pre-COVID, which 37 to 7 days before COVID, acute COVID, 1 week before to 2 weeks after COVID. The reason we went to 1 week before is counting for acute COVID, was talking with a lot of our clinical collaborators. They mentioned that the date that somebody has in their electronic health record as their acute COVID date, they've likely been experiencing symptoms for several days, and they recommended then you go back a week before because they might have already gone to the doctor, have some health status that was actually attributable to that COVID infection. But then finally, the post-COVID period, which is 2 to 4 weeks after COVID. We assessed variable importance via 3 groupings. So one, we looked at individual features. So that's the 304 features across 4 time periods. So that's 1,300 individual features. The reason we did all these groupings was for interpretability, because like just seeing the importance of all of these 1,300 factors isn't going to be super interpretable. So then we also looked at the importance of each of those time periods respectively. And then we grouped based on 14 clinical domains of interest to see kind of what types of linked symptoms seem to be the most important in predicting long COVID. So first, the temporal window. To me, this is the most exciting takeaway from this study, is that we found that baseline characteristics were by far the most predictive of long COVID diagnosis. Ahead of this, so this also includes time invariant factors like sociodemographic factors. I felt really confident before this, as much of our team did, that the post-COVID factors would be most predictive of long COVID. Because, I mean, they're the closest time-wise to long COVID diagnosis. If somebody has symptoms that linger 4 weeks after COVID, are we kind of splitting hairs to say those are post-COVID symptoms or long COVID symptoms? But so the fact that we found baseline factors to be the most predictive was really surprising to me. For one, this supports that clinicians may be able to accurately forecast long COVID risk before somebody ever gets long COVID. And that could potentially enable early recommendation for preventive treatment or continued monitoring. So next, the clinical domain. What we found was that the most predictive characteristics for long COVID diagnosis were healthcare interactions and sociodemographic characteristics. I think on one hand, it's that saying healthcare interaction. So in other words, how often somebody goes to the doctor. It doesn't seem shocking that you go to the doctor more, you're more likely to be diagnosed with long COVID or any other condition, certainly a fairly subjectively defined condition. But then kind of thinking about that a little more, the fact that there's such a big gap between what we believe are the true incidence rates of long COVID and the actual diagnostic rates, this raises some red flags in terms of diagnostic bias, that who are the people, which then seems linked to healthcare access, linked to perhaps socioeconomic inequality, which then we'll follow up on in our third applied paper. But then the third most predictive category is respiratory factors. That I view as kind of the most clear, biologically plausible causal mechanism. So something like folks who have asthma, COPD, some other kind of longer breathing disorder seem to be at greater risk for long COVID. So strengths and limitations here. So we had a really high predictive accuracy of this model. So we found that via external validation, so using kind of a holdout sample of like only training our model with certain study sites and testing them on others, we had a area under the curve, which is essentially kind of like a metric of predictive accuracy of 0.874. And then with the internal validation set, where it was randomly selected, a 0.95. And then we received third place in the competition and a $100,000 cash prize, which is a really fun way to start the postdoc. For limitations, really highlighting here that this analysis sought to maximize prediction rather than make any causal inference. And that my work broadly, so the full name of our research group is the Center for Targeted Machine Learning and Causal Inference. So the fact that this project, I mentioned superlearner and targeted maximum likelihood estimation, this just used superlearner. So we really wanted to follow up on this with some more causal inference focused analyses. So the first we pursued was evaluating the relationship between the use of selective serotonin reuptake inhibitors, or SSRIs, during acute COVID-19 and the subsequent risk of long COVID among patients with depression. I published this in BMC Medicine. So the motivation here is that recently after the long COVID prediction competition, there was a really fantastic article published in Cell by Wang et al. That found that low serotonin was a key driver of long COVID and could explain a lot of these seemingly unrelated symptoms of long COVID. And that there have been a good amount of like posited mechanistic biomarkers of long COVID, but a really cool thing about serotonin as a potential biomarker is there's a really clear pharmaceutical analog. If low serotonin is causing these symptoms, selective serotonin reuptake inhibitors makes serotonin more biologically available, so that should prevent or treat this outcome if it's really being driven by low serotonin. And while biomarker data is limited in N3C, medication data is excellent. We have really good access to whether patients are using SSRIs. So here, I've laid out the hypothesized biological mechanism. So this starts, of course, COVID starts with a SARS-CoV-2 viral infection. That viral infection leads to the release of viral-induced type 1 interferon. So in non-long COVID patients, in standard patients, control patients, the body is able to kind of purge this virus and then they stop having this interferon response. But they found, this Wang et al. Article found that in long COVID patients, there is actually remnants of SARS-CoV-2 viral particles in the lower gut of long COVID patients long after they recover, while they still have these long COVID symptoms. So these remnants of the viral particles then lead to a continued viral-induced type 1 interferon response. These interferons, on one hand, lead to hypercoagulation and platelet dysfunction, already explaining one of our domains of symptoms. But they also, so these interferons prevent the uptake of tryptophan, which is then a precursor to serotonin. So in other words, these interferons prevent the production of serotonin. Then low serotonin also leads to hypercoagulation and platelet dysfunction, kind of reinforcing that pathway, but it also impairs neurologic functioning and vagal functioning, leading to a lot of things that we see of depression-like symptoms, issues with sleeping and waking, sensory disturbances. So that this one hypothesis then explains a lot of the seemingly unrelated symptoms of long COVID. So in this study, we created a retrospective cohort of patients with major depressive disorder, and we evaluated the relationship between SSRI use during acute COVID-19 and the 12-month cumulative incidence of long COVID. We just restricted to patients with depression here to reduce confounding by indication, as depression is a really common reason for SSRI prescription. We also rigorously adjusted for healthcare utilization and comorbidities, and we intervened on patient follow-up to ensure that they were all monitored or get the counterfactual status if they were all monitored during the outcome period. So here's our results. And what we found was that SSRI users had a lower risk of long COVID in our fully adjusted model compared to non-users. So about an 8% reduced risk of long COVID among SSRI users compared to non-users. And we didn't find strong evidence of a heterogeneous relationship depending on the type of SSRI, which was consistent with our kind of clinical and psychiatric colleagues' hypotheses about the different subtypes of SSRIs. So for our discussion, we found that SSRI use during acute COVID-19 is associated with reduced risk of long COVID among patients with depression. This supports SSRIs as a potential intervention for long COVID, but it also provides indirect support for this whole hypothesis that we mentioned earlier. So that implicates the SARS-CoV-2 virus or viral particles, viral-induced interferon 1, and tryptophan as potential mechanistic long COVID biomarkers that could be used to measure long COVID or perhaps intervened on to prevent or treat long COVID. So now I want to go back to our previous figure, but highlighting the pathways that have really been underscored by our findings. So as I mentioned, this really provides support to the argument that persistent SARS-CoV-2 virus or viral particles play a role in long COVID. Similarly, this continued interferon response or inflammation also plays a major role. That, as I mentioned, the inflammation and stress systems are so intertwined. So that kind of implicates the importance there. And then we mentioned the hypercoagulation that's driven by the interferon response, as well as decreased serotonin. So highlighting that pathway as well. So next, and this is kind of the third and final applied example, we had mentioned before the fact that long COVID is so associated with healthcare utilization, how often somebody goes to the doctor. And there's a big gap between the true, what we believe is the true incidence rate and the observed diagnostic rate. So that's often been attributed to the subjective criteria used for diagnosing long COVID, limited treatment options. So for a lot of clinicians, it's like, well, what's the benefit of me diagnosing you with long COVID? Because it's mostly going to be symptomatic treatment. And then variations in healthcare access and healthcare quality. A lot of patients, there's a really fantastic qualitative study that describes the experience of long COVID patients, where they describe this medical gaslighting, where their symptoms are often not taken seriously and dismissed, and they really have to see a lot of specialists over a lot of time. And a lot of people just don't have the resources to do that. So the research question here is, if a patient has long COVID symptoms, does the probability of being diagnosed with long COVID depend on the patient's race and ethnicity? And this is currently under peer review at Health Affairs. I just submitted it there a couple weeks ago. So for methods, we included a sample of electronic health records from N3C once again of about 2.4 million patients that were all diagnosed with COVID-19. We included 6 racial and ethnic categories, 222 symptoms of long COVID. And then we observed both the symptom status and long COVID diagnosis in the 12 months after their acute SARS-CoV-2 infection. And so we assessed the relationship between race and ethnicity and long COVID diagnosis, excluding the indirect relationship that's mediated through symptoms. And in other words, this is the controlled direct effect. This is a similar approach that's been used to evaluate gender bias and promotion, where in that case, in terms of assessing gender bias, it was excluding the indirect pathway that was mediated through job performance, where in this case, the assumption is that long COVID symptoms should largely determine long COVID diagnosis. And the assumption there was that job performance should largely determine promotion. And that we adjusted for age, sex, comorbidities, SARS-CoV-2 infection date, and we similarly intervened on healthcare utilization, as we did in our previous study. The analysis methods we used were longitudinal targeted maximum likelihood estimation, which is, as you could probably guess, targeted maximum likelihood estimation when we're dealing with time-dependent factors in this longitudinal setting. So for results, what we found was that Black patients were 6% less likely to be diagnosed with long COVID than white patients despite equivalent symptomatology. And I can just kind of pause here for a second to digest a little of this. And we did not find a significant controlled direct effect or significant racial bias in other racial and ethnic groups compared to white and non-Hispanic patients. So our conclusions here are that racial bias seems to be present in long COVID diagnosis among Black patients compared to white patients. The magnitude of this bias was small, as I mentioned, around 6%. But I also want to highlight here that this is a pretty conservative comparison, that we aren't contrasting that what I think could also be an interesting contrast if we had the gold standard of somebody's true symptomatic profile. But what we're contrasting here is folks who go to the doctor, have documented symptoms, but then those documented symptoms, whether that leads to a long COVID diagnosis. So I think we would see, I hypothesize that we would likely see a much larger effect if we had this kind of true diagnostic status, because a lot of things like access to healthcare are going to contribute to kind of the same biases in terms of documented symptoms as they would with documented diagnosis. So although the magnitude of this bias was small, I do believe that it's clinically significant and highlights the need for interventions here. And so there's a lot of different interventions that could address these disparities. So implicit bias training. And another key one is just really the need for objective diagnostic criteria for long COVID. Although, of course, with even objective diagnoses, we do often see evidence of racial and ethnic bias. So I don't mean to misconstrue that would be some kind of silver bullet to totally stop any bias in this setting. So now for future steps of this work. So COVID first, this is a study, and I've kind of denoted with an asterisk the studies where the manuscript is finished and is kind of circulating among co-authors before submission. So we're evaluating the relationship between COVID-19 vaccination timing relative to acute COVID-19 and how that relates to the subsequent risk of long COVID. So in other words, if you receive a vaccination or booster today, and then you get COVID a month later, versus you get COVID 6 months later, is there a different probability that then you'll subsequently develop long COVID? And that I hope that this study will help inform vaccination schedule guidelines. I'm also leading an analysis. So I think through this time with N3C, applying targeted machine learning methods, there's been a lot of methodological lessons learned. So I've written up a manuscript outlining best practices in seeking causal inferences via electronic health record data, where it's really using long COVID and targeted machine learning as the continued example throughout the paper. Then I'm leading a couple of different emulated target trials. So first, we're looking at the impact of metformin on long COVID among diabetes patients. And so we're looking separately among cohorts of prediabetes, type 2 diabetes, and PCOS patients. And to then take a step back, an emulated target trial is when you take observational data, like electronic health records, and then structure them as if they were a randomized controlled trial to really try to get at that causal impact of an exposure intervention. Then we're also looking at the impact of immune modulating drugs to really test that cytokine storm hypothesis, the impact of that inflammation pathway. The impact of immune modulating drugs, more specifically tocilizumab and sarilumab, on the risk of long COVID among rheumatoid arthritis patients. In both of these settings, these are conditions that would likely lead to a prescription to one of these drugs. And a hallmark of an emulated target trial approach is often that it includes an active comparator new user design. So there will be multiple therapeutically equivalent treatments that would trigger an individual or patient's inclusion in the study. So then you view that moment of prescription to one of those drugs as the moment of randomization. So we would include diabetes patients who are prescribed to metformin or a comparable alternative. And similarly, one of these immune modulating drugs or a therapeutically equivalent alternative. We're also following up on the SSRI study to look at the relationship between SSRI use during acute COVID and long COVID symptoms. So in the previous manuscript that I shared, we used long COVID as a binary definition. So that's ICD code U09.9. But that this kind of blends a lot of our methods from the racial bias work and the SSRI work, in that we look at the relationship between the use of SSRIs and all 222 individual symptoms of long COVID. So here what we really want to test is whether maybe SSRIs are very effective in preventing neurologic long COVID symptoms, but aren't as effective in preventing the inflammation long COVID symptoms. We're also following up on our racial bias analysis to evaluate the presence of rurality bias in long COVID diagnosis. So it's been documented across other sources that a lot of the time rural patients might have less access to specialists, or it really takes a lot more work for them to see a specialist. So we'll see whether, similarly, given equivalent symptomatology, whether there's a significant evidence of racial bias, bias based on rurality. I also just received affiliate status at the UCSF in their Department of Anesthesiology, so that I could access the University of California Health Data Warehouse, which is about 10 million patients across California, where I hope to reproduce a lot of these findings with a unique sample. So in summary, just to summarize the main findings of our papers, first, we can accurately predict long COVID diagnosis from baseline patient characteristics. SSRIs may prevent long COVID, and serotonin may be a mechanistic biomarker of long COVID. And Black patients are less likely to be diagnosed with long COVID than white patients with equivalent symptoms. But many questions related to long COVID remain unanswered. I think it's really an exciting area of research, and I plan to continue pursuing this research area. But also in the context of, I view my expertise as really being on applying causal inference methods to observational health data. So yes, I want to continue applying this to long COVID, but also to other research areas, because I think that this could really help us answer a lot of really key health-related research questions. And I'm always interested in collaboration. So please feel free to reach out if you have any questions or would be interested in exploring the possibility of working together. I really just want to thank an incredible team. So I think my team at the UC Berkeley Center for Targeted Machine Learning, just fantastic and just really incredible folks that I'm really grateful to work with, as well as at N3C broadly. If any of you are interested in working with that data source, I've been blown away by the collaboration. Oh, sorry, I hear a question. Oh, sorry. I've been really blown away by the collaboration, openness, support. Every person I've reached out to will say, yes, can I share code? Do you want to meet? Let's collaborate. So I really cannot say enough great things about that. And I'm grateful to my funders. As I mentioned, the NIAID funds some of my work through my KO1 for the next 5 years, and that I was previously funded by a global development grant from the Bill and Melinda Gates Foundation. So thanks so much to all of you for attending. I really appreciate it. And you can read more about my work here. And feel free, please send me an email if you have any questions or would like to talk more.
Zach, thank you.
Thank you.
Interesting. Some kind of work I hadn't known before. I didn't know much about what called the ring trial.
Oh, the ring trial. Yeah. I'd be happy to talk about that.
Well, that's not actually question, but I'll talk about that one on the side. It might be a little too nerdy for them. My question, so you mentioned interventions on one of your slides, and I was taking that mostly clinical or how we train clinicians. How far, based on what you're doing, are we from more community-based intervention or public health policy? And let's say we're closer to that, what might those look like?
So that's a really great question. And I had a great conversation with Bettina about this morning and let me scroll back a little bit. So I think in particularly where we're seeing kind of systematic bias in long COVID diagnosis, and one that I think is practical, although I think is very practical, but I think is working I think there's kind of two different directions. I think that there's the ideal approach, which is that clinicians will diagnose this more equitably, that there'll be more equitable access to healthcare in general, that there will be more equitable access in the distribution and quality of healthcare. But I think another, unfortunately, plausible thing at this point is that so much of the outcomes and diagnostics policies is coming from patient self-advocacy. So there is another community angle, and I've been hearing a lot actually from excellent local researchers on health communication. From Matt also told me some great work about this today of educating patients or community members about things like long COVID, because at the moment, a lot of these diagnoses are coming from people going to their clinician and saying, I think I have long COVID. So I also think there's really great work around implicit bias training, which I think, is not quite as much of a community-based intervention. But I certainly think that there's a lot of potential intervention points there.
Great.
Awesome, thank you.
Does the big data set have place level information?
Yes. So
How specific?
How specific is, so that is one of the areas that I bet unsurprisingly, they're the most touchy about, because particularly the data provider. So we can't publish for the most part anything related to that because their big concern, I mean, of course, number one, not identifying patients, but also not wanting us to re-identify study sites. And that geospatial information is very key to that. So they often can be used in analysis, but can't be published. So I believe that geospatially, it gets as close to so a lot of socioeconomic factors and social determinants of health, we have only at the county level. So it'll be like a county average, which is a little bit limited, but then it gets as close as the zip code per patient.
Rachel's smiling at me. I think she knows where this is going. I'll tell you what I was thinking is, so serotonin is lower at high elevation, and SSRIs work less effectively at high elevation. And so I was wondering if there was a way to look at sort of elevation of residents to see whether whether long COVID is more common in those places and whether it modifies your finding.
That is incredibly interesting. And I'm feeling shocked that this is my first time hearing this. That's really interesting. So yeah, I would love to pursue that more. And I
I just
believe,
didn't know if it was possible with the data sets that you have.
and I believe that I think it might take some, so I think we do have some excellent collaborators who work in kind of the GIS space. So I don't think that there would be like elevation directly in the data source, but I think getting elevation at the zip code level, I think is a very plausible, and I think is it's a really interesting research question. So thanks for that question. Yes.
I have a question about this one specifically, and I'm sorry if you said this. Is there, I guess I'm trying to understand what is the value of getting a long COVID diagnosis, as opposed to maybe if these physicians are diagnosing people with long COVID, but they're still treating their symptoms. Like, why does it matter to get the long COVID diagnosis?
That's a great question. So I think that there's now like several treatments for long COVID, and not incredible data on the relative effectiveness of each. So I think a lot of the treatment is going to be symptomatic regardless. But I think given a lot of recent support for this persistent SARS-CoV-2 pathway, there's a lot more support coming for antiviral treatment. And I think that a lot of those kind of treating the underlying mechanism, that relationship between diagnosis is going to be important. I think furthermore, particularly related to these kind of this evidence of racial and ethnic bias, I think a lot comes into our understanding of treatments is likely to be biased if we're then creating what we're really doing here in all of these randomized trials that seek to treat long COVID. If we have a biased sample of long COVID patients, that's probably going to bear through in the treatments. And we've seen that across a lot of public health interventions that are much less effective in communities that are underrepresented in these trials. And that's to say often, so.
Just a follow up to that,
Mhm.
is it, can a long COVID diagnosis change one's disability status? And would that be a reason that this matters?
Oh, that is a great question that I'll have to look into because I'm not 100% sure the status of that. I know that it is there's really staggering figures with kind of with like leading to functional disability in terms of lack of ability to work, but in terms of like the legal ramifications, I'm not fully aware. Yes, Rodrigo.
Zach, a wonderful presentation.
Thank you so much.
Such an engaging speaker, by the way.
Well, thank you. I really appreciate that.
Let's go back, but I will have to go back to the place-based conversation. So outdoors and sun exposure also relates to serotonin levels.
Mhm.
So time spent outdoors
Mhm.
and exercise as well. So have you considered those two? I see two conversations. One as moderator, sort of or even mediator pathway. Other back to what Ross was asking, place-based interventions for long COVID patients or something like that. Have you ever had those conversations or thought about those elements?
So I think it seems like a really exciting direction. I think that one thing that's been really cool about working in this long COVID space, I think, has been the overlap with, of course, long COVID, like COVID is pretty new, but the overlap with other outcomes. So specifically overlap with other kind of post-viral conditions. So it's a good amount. I think kind of the most direct comparison I've heard a lot is with chronic fatigue syndrome, or ME/CFS, which I think really hoping that as we get more answers to long COVID, that we can also more effectively treat this outcome. Then a lot of comparison to chronic Lyme disease as well. And even some syndromic overlap with HIV. Sorry there's a bit of a non-answer because I think that would be really interesting to look into these types of place-based interventions, outdoor time, physical activity. But that's not something that I really have a great grasp of or that we've dove into yet. I think that we would likely need to supplement, which I think would be totally plausible, the data in N3C with another data source, unless we kind of inferred a lot based on geospatial information, which I think whether we wanted to, it would be easy to import like number of sunny days per year, that kind of aggregate level data. But I think getting individual level data would probably take a little bit more legwork, but I think it would be a really worthwhile thing.
So just a final comment.
Yeah.
For 2 days at least, a wonderful Center for the Environment, conversation that we had, hosted session with students, and some of our colleagues in the School of Engineering and the School of Medicine are tracking sun exposure at an individual level, using accelerometers with sensors for light exposure. So I think there's potential for individual level sort of tracking for cohort studies, perhaps. Since this is one of the major factors for natural ways for you to be exposed to higher levels of serotonin, perhaps. There's something for interdisciplinary conversation perhaps.
Absolutely, and I would love to talk about that more. That seems like a really exciting idea.
Yeah.
Thanks, Rodrigo.
Really great presentation. I
Thank you
learned
so
a
much.
lot. So, when you were talking about this is all adults, right? Is this data set all adults, or are there any children in it?
There are some children in it.
Have you looked at children in terms of long COVID, and I don't know the extent to which they have it. Obviously, they have less COVID. But I'm wondering if that's something of interest to look at, because you are talking about growth and development and different, whole different set of parameters, and if there's interesting data there to look at.
So it's definitely of interest, and there was actually a really cool paper published like last week that was the impact of vaccination on long COVID among children. I think it was published in Nature, but it's a really fantastic study. I think we are definitely really interested. I think one of the challenges, so N3C has some children, but definitely undersampled children. It's definitely majority of adults. In our emulated target trials, looking at drug interventions, we did restrict to 18 to 65. Or in the ones that will be coming out, we restricted to 18 to 65. But I think because children do have less long COVID, but they do have long COVID.
Right.
And that long COVID is weird in that I think a lot of like predicting likelihood of long COVID risk assessment is a lot of like the usual suspects of comorbidities, age, immune suppression all make one more vulnerable, but that similar to COVID severity, there's a good amount of folks who had only a mild infection or otherwise healthy and then are debilitated for years. And that it seems like such a unique pathway that in comparison to a lot of other illnesses that seems to just raise a lot of questions because it's not always these usual suspects of what implicates somebody.
And hard to diagnose, as you said, and with children in particular. And I wondered about any biases there.
Oh, that's a great question.
Potentially.
Yeah, I think that seems totally plausible. I don't fully know the data on that, but I think that would be an interesting study.
Yeah. And there was others, I'd seen reports of increased hyperactivity. I don't know if that was just self-report or, but it all goes into part of the diagnosis of symptomatology, especially.
Absolutely. And I think that one thing that we really debated a ton is then how to incorporate disability as well, where for these types of like diagnostic biases that where often if somebody comes in with a disability, then the clinician may attribute these symptoms to the disability. And often like other studies have found for these subjectively defined disorders that an individual with a disability is less likely to get diagnosed. So I think that that's an area of interest as well, and really led us to debate the merits of adjusting for disability status and comorbidity burden versus not adjusting for it. And I think there's good arguments for both. So.
Thank you very much, Zach. That was great.
Thank you so much.